Hello everyone, my name is Dana Ambler and I'm one of the physicians at Denver Fertility, and today is our first webinar and we're going to be talking about in vitro fertilization, and this is going to be a topic for us to just talk some basic general information that you guys might want to go ahead and actually know about in vitro fertilization. So this page is a little bit about me. So I am a physician again at Denver Fertility and have been here for about 1.5 years. And I really do go ahead and pride myself on taking care of patients just like I would my family. And so realistically, when you go ahead and come to see us at Denver Fertility, we do want you to go ahead and feel like your family. So infertility actually is strictly defined as 1 year of unprotected intercourse without conception. However, female age can go ahead and play a role in this. And so we tell patients, if you are greater than 35 years old, but less than 40 years old, you should probably try for approximately 6 months and then seek an evaluation. And if you're greater than 40 years old, you should seek an evaluation immediately. We know that about 1 in 7 couples actually have problems trying to conceive, which means that about 90% of patients will go ahead and conceive within the first year of trying to go ahead and actually get pregnant. There are many different types of infertility treatment, and we really, again, pride ourselves in trying to go ahead and individualize your treatment as much as possible, specifically to what your diagnosis for infertility is. But some of the options are listed here, so we can definitely go ahead and look at an option for surgery if you have problems with endometriosis, fibroids, scar tissue within the uterus, for example. There's also fertility medications that you can take by mouth or by injection to go ahead and actually help with egg development and egg recruitment, as well as ovulation if you have a problem with ovulation. We can look at intrauterine inseminations where we can deposit sperm into the uterus. And we can also look at in vitro fertilization as a fertility option, and that's what we'll concentrate on today. So when we talk about in vitro fertilization, basically it's combining husband's sperm as well as wife's egg outside of the uterus in a laboratory environment. And it actually involves quite a few different steps that we'll go ahead and actually talk about today. So we'll talk about how do we go ahead and get multiple eggs to go ahead and actually develop all at once. We'll talk about how we retrieve the eggs from the ovary, fertilize the eggs with sperm in the lab to create embryos, which are early pregnancies, how the embryos will develop in the actual environment in the laboratory, and then what the transfer of the embryo back into the uterus looks like as well. This process actually has been around for quite a long time, and the first successful birth was in 1978. After IVF treatment, and Louise Brown was actually the female that was delivered. So when we look at IVF, it's really a big sequence of highly coordinated steps that actually begin with just the injectable fertility medications that we use to go ahead and actually grow the eggs in the lab. We then, again, retrieve the eggs out of the ovary with a tiny little needle. We create the embryos in the lab by combining egg and sperm together. We then have the embryo grow in the lab for a few days, and then we can transfer the embryo back into the uterus using a small little catheter through the cervix and into the uterine cavity. So who does need IVF? Well, there's a lot of different reasons now that we can go ahead and actually utilize the IVF procedure. One is if patients have fallopian tube disease and their tubes are blocked, because then there is no way for the egg and sperm to go ahead and meet, and we're able to bypass the fallopian tubes by using the IVF process. Patients that have endometriosis are also very good candidates for in vitro fertilization. Male factor infertility, so if there's abnormal semen parameters, that can go ahead and actually be somebody that is very advantageous to use the IVF process for. And actually, male factor infertility was why IVF was actually created in the first place. If you have unexplained infertility, if you're at an advanced reproductive age or have something called diminished ovarian reserve, IVF can go ahead and actually help. If you have premature ovarian failure, if you have Müllerian anomalies where the uterus is not shaped exactly how it should be, if you have medical or genetic diseases that would go ahead and actually make IVF a better option for you, or if you've gone ahead and actually tried some less invasive treatment options and unfortunately have failed, then IVF is a good option for us to look at for you as well. So there are a lot of prognostic factors that go ahead and actually make IVF successful. And one of them actually is maternal age, the age of the egg, and where that goes ahead and actually puts patients into a category as far as success for pregnancy. So when we talk about IVF, we really go ahead and talk about what your chances of success would be with IVF based on your diagnosis. And what we know about maternal age and female age specifically is that the eggs actually are very finite for us. So we as women are born with the number of eggs that we get for our entire lifetime, and we don't make more eggs like men do sperm. And knowing that information goes ahead and then tells us also that typically at the age of 32 years old, we usually start to see a decline in the quality and the quantity of our eggs. And at the age of 38, we start taking a little bit of a steeper slope in that decline. So looking at success for IVF really goes ahead and makes a difference as far as age is concerned, as well as egg health. When we go ahead and actually start looking at the process of the IVF procedure, like I said, we start with that stimulation of egg development. And that is typically going ahead and taking some injectable fertility medications, on average about 8 to 12 days worth of that cycle. We want to go ahead and see multiple eggs develop. The more eggs that we can go ahead and to develop, the more embryos we potentially create, and the more chances of success for patients to go through the IVF process. What we want to go ahead and see is as many eggs go through that same similar stage of development and kind of grow in a group, because that goes ahead and gives us more maturity when we go ahead and take the eggs from the ovary. The biggest risks that go ahead and actually happen with the stimulation of egg development is that you're taking these injectable medications and multiple eggs are growing. So there's always the possibility that we could go ahead and look towards something called ovarian hyperstimulation syndrome. And that's where the eggs go ahead and actually get very big and distended, and it can go ahead and actually cause us to hospitalize you if you start to look towards something like ovarian hyperstimulation syndrome. But the risk is extremely low. When you look at nationwide IVF cycles, the risk for ovarian hyperstimulation is less than 1%. The other concern and other risk that we always worry about with the IVF process is the risk of multiple pregnancies. You know, patients can go ahead and actually have multiple pregnancies, but by going ahead and being conservative with treatment and going ahead and limiting the number of embryos that we put back into the uterus, we can typically go ahead and reduce that risk of multiple pregnancies as well. So we actually see more multiple pregnancies in treatment with Clomid or Letrozole, for example, and inseminations than we do actually with the IVF process nowadays. So when we talk about the medications that we need to go ahead and actually give, we go ahead and actually teach you how to do those medications, and they are given underneath the skin, typically in the belly, and it's what we call a subcutaneous injection. During that stimulation, we also tell patients that you'll go ahead and actually be in the office quite frequently for blood testing and ultrasound monitoring. And what you can see on the right side of the screen is what the ultrasound would look like as we measure the follicles. And the follicles are basically the fluid-filled sacs that the egg sits inside of, and that's how we can go ahead and tell when the egg is mature. The oocyte retrieval process is towards the end. So once we go ahead and actually get a majority of these eggs to go ahead and grow, we want to go ahead and actually then pull the eggs out. And we do that actually with a process and a tiny little needle through the back part of the vagina. I see that there's a question actually, and the question is the egg retrieval process painful? No, it's actually not painful, because what we go ahead and do is we actually give you some light anesthesia during the egg retrieval process, which typically lasts about 20 to 30 minutes. And so you sleep through a lot of that little pinprick that we go ahead and actually have from the needle, as well as that aspiration of all of the follicular fluid to go ahead and get the eggs out. Typically, patients go ahead and actually go home that day, maybe with a little bit of Tylenol to help them with some cramping, but most patients don't take any medications whatsoever after the egg retrieval because they feel okay. Most patients also can go back to work even the next day after their egg retrieval process. So when we go ahead and actually look at egg retrievals, again, we always want to go ahead and talk about risk versus benefit. And one of the complications that we can go ahead and see with egg retrievals is that we can go ahead and actually get some bleeding into the ovary. Most of that bleeding goes ahead and actually stops on its own and goes ahead and actually clots off. Just like if you cut yourself on your arm, and you went ahead and actually held a little bit of pressure, it goes ahead and clots off and stops bleeding. Our ovaries do the same thing. We do know that there is a small risk for infection, and so a lot of physicians will typically go ahead and actually give antibiotics during the egg retrieval process to prevent and reduce that risk of infection as well. So when we talk about actually the number of eggs, this will vary from patient to patient. And again, a lot of that goes ahead and depends on how many eggs we can go ahead and actually get from the patient based on their age for the female, as well as their egg health when we go ahead and do their evaluation. So we typically go ahead and see an average of about 8 to 12 eggs in a healthy female. We also go ahead and see maybe about 90% of the eggs going ahead and being mature. And those are the eggs that can get fertilized with sperm and become embryos. About 80% of those mature eggs will go ahead and fertilize when sperm is actually utilized to inject. And then 60% of those embryos typically will grow in culture. So again, everybody is a little bit different, but these are kind of averages just so that you know kind of a rule of thumb. Then what we do is we go ahead and actually get the sperm specimen that same day that we go ahead and do the egg retrieval. And that is typically a sample that's given by masturbation. And then we go ahead and wash that sperm so that we get the best quality sperm to go ahead and actually utilize. And there's two options. We can either go ahead and do what's called conventional microinsemination, where we go ahead and layer the sperm over top of the egg and allow it to fertilize naturally like it would inside your body. Or we can go ahead and actually use a process called intracytoplasmic sperm injection, or ICSI for short. When we go ahead and actually look at ICSI procedures, we want to go ahead and know the actual content of the egg as well as the sperm. So you can see, egg is that big circular structure towards the top of the screen, and the sperm is that tiny little structure towards the bottom of the screen. And what we can do with the ICSI procedure is take a sperm cell, so take one sperm and actually inject it into the egg. So we can bypass actually the shell of the egg, which sometimes doesn't allow penetration of the sperm to go ahead and get in. And it goes ahead and allows activation for fertilization to take place by injecting the sperm. And this will decrease fertilization quite considerably nowadays in the IVF process. When we go ahead and actually look at an embryo underneath the microscope, we can go ahead and see actually the DNA and the chromosome content of the egg and the sperm coming together. And then we go ahead and grow the embryos typically in the lab for about 5 days. And you can see at the very bottom of the screen that a blastocyst embryo is typically what we go ahead and look at transferring back into the uterus. And the reason why is because that embryo is a very hardy embryo. It is over 150 cells big at that point in time, and it has a much higher chance of implanting and sticking to the uterine surface than an embryo in a cellular stage, like you can see 4 cells and 8 cells on the screen. So when we look at actually a blastocyst, it goes ahead and shows us some really important structures. The inner cell mass, which is going to be the clump of cells that goes ahead and actually becomes your baby. And then the trophectoderm, which is that outer shell that goes ahead and actually becomes the early placenta. And these are important to go ahead and look at, because one of the options that you have when you look at the IVF process is something called PGD, PGS, or CCS. And those are all different kind of combinations of letters, but a lot of it goes ahead and still talks about the same testing. So when we talk about pre-implantation genetic diagnosis, or PGD, for example, that goes ahead and allows us to look actually at chromosomes for a specific genetic disease and the genes that go ahead and actually cause those genetic disorders, and test actually specifically for that genetic disorder. So things like cystic fibrosis, for example, which can be a lung disorder in a child, we can go ahead and actually look in the embryo for. Pre-implantation genetic screening, or PGS, goes ahead and actually allows us to look at the DNA and the chromosome structure within the embryo. So this allows us to go ahead and look at embryos that might have a normal chromosome complement and go ahead and utilize those embryos to put back in. But it also goes ahead and allows us to look at embryos that might not necessarily have the right chromosome complement, an increased risk of miscarriage or increased risk of birth defects as well. I have another question that goes ahead and actually asks, do you always recommend PGD? And the answer is no, we do not. So we typically go ahead and tell patients that this is their decision to go ahead and actually look towards PGS or to look towards chromosome testing. However, depending and stuff, again, on maternal age, why they're looking at doing IVF, and what kind of options they want to go ahead and offer to go ahead and look at pregnancy success rates and to mitigate that risk of miscarriage and birth defects, we can definitely go ahead and offer it. So when we look actually at the process of going ahead and actually testing these embryos, what we typically do is take a few of the cells from that outer shell, from the trophectoderm of the embryo, well away from that inner cell mass, so that the chances of the embryo being injured are very low. That little biopsied sample of those few cells then gets sent off to a lab for analysis, and the embryos typically are frozen at that stage. For the embryo transfer process, what we typically go ahead and look at is actually a couple of different pieces of information to go ahead and afford patients a better opportunity actually to go ahead and have success with their embryos. So one of the options that we can go ahead and actually offer patients is to go ahead and grade embryos. So we will actually look at cell number, we look at the symmetry of the actual blastomeres or the cells that are forming within the embryo, we look at if there's any fragmentation or debris, and we look at actually how fast the embryo is going ahead and dividing. Because all of those things go ahead and allow us to grade an embryo, and the grading is very different from lab to lab. But obviously the better looking embryos typically have the higher chances of being successful and going ahead and implanting and becoming a pregnancy. With the embryo transfer process, we typically do go ahead and do it under ultrasound guidance. We usually go ahead and do a trial transfer ahead of time, so basically a dry run of putting the embryo into the uterus, because that goes ahead and avoids us from having any trauma, mucus, blood within the catheter that could go ahead and lower the chances actually of the embryo successfully implanting. So somebody actually asked about how many embryos do you transfer on average, and that's the next thing that we're going to talk about. So the number of embryos to transfer is very specific, again, to the patient and to the couple. Most patients actually are under guidelines of the American Society of Reproductive Medicine as far as how many embryos to go ahead and actually put back into the uterus. We are typically very conservative nowadays just because the chances of pregnancy with the IVF process are so much higher than they had been in the past that we typically go ahead and try to reduce that risk of having multiple pregnancies. So we normally tell patients 1, maybe 2 embryos at the very, very most, and that will hopefully go ahead and give a successful pregnancy, but keep that reduction in the risk actually of having twins or higher order multiple pregnancies. So when you go ahead and actually look at the chances of pregnancy, we know, just like I said before, that these embryos typically do better if they are at a higher level as far as growth within the lab. So when you look at cleavage stage embryos, which are embryos that are in a cellular stage, versus blastocyst embryos that have started to compact and actually get ready to go ahead and develop and differentiate further, those embryos typically go ahead and do much better when we go ahead and do a blastocyst transfer than a cleavage stage embryo transfer. But as you can see, this is actually from the American Society of Reproductive Medicine, and it basically goes ahead and shows how many embryos we should be transferring based on female age and based actually on couples and their preference for the number of embryos. So one of the other things that we go ahead and actually talk a lot about is what happens after we go ahead and actually put the embryos into the uterus. Most of these cycles, when we go ahead and do embryo transfers, are frozen embryos. And the reason why is because it does go ahead and afford us the opportunity to go ahead and do that PGS and CCS testing on the embryos and still give a good chance of the embryo going ahead and implanting onto the uterine surface. The other reason why we go ahead and freeze embryos is because nowadays there's some very good literature to suggest that actually frozen embryos do just as well as fresh embryos do. And also some literature to suggest that putting back frozen embryos goes ahead and actually is better for mom as well in reducing risks as far as preterm labor and preterm delivery, as well as problems during pregnancy like diabetes and high blood pressure issues. When we talk actually once we've put the embryo into the uterus, because of these frozen cycles, we usually go ahead and actually give a lot of support to the lining of the uterus and then to the pregnancy afterwards when we put the embryo into the uterus. So there are a lot of actually medications that patients are going ahead and taking through the entire IVF process. First, to go ahead and grow the eggs, and then second, to go ahead and actually support the pregnancy. So you can see some of the medications that we typically go ahead and utilize. So everybody always goes ahead and asks me in their consultation about success rates. And really, when you look at success rates for IVF, it really, again, depends and stuff like that on your diagnosis. And that's why at Denver Fertility, we are really very specific in making sure that we get your diagnosis right and that we can go ahead then and afford you the best chances of being successful with your fertility treatment. So we know that natural rates for pregnancies is typically somewhere around 20 to 25% per cycle. With infertile couples, we know that their chances of pregnancy are much lower. It's usually about a 1 to a 2% chance of pregnancy per month that they try. And with all of the options that we have for fertility treatments, we can usually go ahead and at least get patients close to their normal chances for pregnancy, or with the IVF process now, much higher chances of pregnancy. And when you look nationwide, a lot of the pregnancy rates are over about 55% and greater, depending, again, on chances of success based on that diagnosis and based on maternal age. So one of the other questions that I'm getting is that, is there an increased chance of birth defects with IVF? Unfortunately, there is some birth defects that are a little bit higher in incidence with the IVF process. So for example, with the ICSI process and us injecting sperm into the egg, there is a higher risk of something called hypospadias in males, which is actually where the opening of the penis goes ahead and actually occurs on the bottom side of the penis instead of at the tip top of the penis. So there are things definitely that we would go ahead and actually talk about during a consultation so that you guys understand that there are some increased chances of problems with the IVF process. However, that being said, when we look actually at a lot of the literature that's out about IVF and the risk of birth defects, we don't know whether or not the risk is really truly due to the process of IVF, or if it's actually more due to the process of actually the patient and the couple having a diagnosis of infertility. Because we do know actually that patients that are infertile have higher risks of birth defects than patients in the normal population that are able to get pregnant on their own and do not seek any fertility treatment. One of the other questions that I'm seeing is that, is there a higher risk of miscarriage with IVF than with anything else? And actually the case is not. So typically miscarriage rates actually, again, are based off of female age, and that's because of actually the quality of the egg. In our 20s and 30s, we actually have very good quality of eggs. That's typically when our higher chances of pregnancy are, and that's when our bodies are using our good quality eggs to go ahead and get pregnant. So the miscarriage rate then is a lot lower. In patients in their 40s and 50s before we reach menopause, those poor quality eggs are the ones that have been left behind, and that's the reason why we typically do go ahead and see higher risks of miscarriages in women that are older than 40 years old. So this is actually just a screenshot to go ahead and show you about what I was saying, that a lot of the IVF results nowadays, especially when we go ahead and look at nationwide data, and this is very old data actually if you look at 2008, now we're looking at much higher chances of pregnancy and being successful with the IVF process. So again, risk versus benefit, and we'll go ahead and actually go through a couple of the risks with IVF. Like we talked about multiple pregnancies. And again, pregnancy success rates will go ahead and increase slightly based on the number of embryos that we transfer, and more importantly, based off of the age of the patient. And so talking actually to the couple about how many embryos to transfer and what that risk of multiples goes ahead and actually could be for that patient is really important before we put embryos back into the uterus. One of the other risks of IVF is ectopic pregnancies. There are a lot of misconceived thought processes when it comes to IVF and ectopic pregnancies, that because we're not using the tubes that we won't go ahead and actually get an ectopic pregnancy. But unfortunately, because the embryo is placed in a little droplet of fluid and then transferred into the uterus, it has to go ahead and implant on its own. And when it has to go ahead and implant on its own, the embryo sometimes will float around in that fluid and sometimes can go ahead and actually migrate to the fallopian tube. So definitely it's something to go ahead and consider and think about, and obviously talk with your physician. Again, we talked about ovarian hyperstimulation syndrome being a very big deal and a risk for IVF, and certainly can go ahead and actually be increased for patients with polycystic ovarian syndrome, for example, because those patients typically can go ahead and actually create a good number of eggs and then have very high estrogen levels. And we know that ovarian hyperstimulation syndrome can be linked to a high dose of the injectable fertility medications or the gonadotropins, but also to those high chances actually of estrogen levels towards the end of the retrieval. So this is actually a slide to go ahead and talk a little bit more about that initial question about increased chances of birth defects. So just like I said, we know that most of the time, IVF does not go ahead and increase the risk of huge birth defects, but can go ahead and obviously increase chances for low birth weight for patients that we have gone ahead and seen in the past. So what I always tell my patients during consultations, because I always get asked this question of what can I go ahead and do to really help me increase my chances that IVF will be successful? And so what we talk about is really just a healthy lifestyle. If you are overweight or obese, losing weight will definitely increase the chances of you going ahead and getting pregnant and being successful. There have been studies in the past to go ahead and show that if your body mass index is less than 30, it can go ahead and increase your chances of IVF being successful by almost 50%. Eating healthy, having some moderate exercise is really important to go ahead and obviously, one, keep you healthy during the time that you're going through fertility, but also to have a good mindset of being healthy during your pregnancy as well before we actually go ahead and get you pregnant. We always tell patients that tobacco smoke, any marijuana use, excessive alcohol, as well as a lot of caffeine can go ahead and actually affect fertility, as well as actually caffeine affecting the risk of miscarriage. We tell patients to go ahead and stay away from a lot of supplements unless they're supplements that we know can go ahead and actually improve ovarian health, improve male sperm health, or it's something that has gone ahead and actually been given by your physician or by an acupuncturist. You can see that I'm a huge advocate for acupuncture. There is some limited data to say that it goes ahead and actually helps with the IVF process, but more than anything, I think that it is a great stress reliever as you go through this process of IVF that can go ahead and actually be a long process for some patients. And one of the other things that you can go ahead and really do to improve your chances of being successful with IVF is to just make sure that you understand everything that your physician goes ahead and talks to you about. You will be inundated with so much information and so many instructions that we always just want to make sure that you're understanding everything. And that's also the reason why we're always available for questions and for comments, as well as you going ahead and coming into the office to make sure that you understand how to go ahead and actually do everything as you go through this process. So like I said, this is actually that study to go ahead and look at weight and IVF success and really trying to go ahead and increase the chances of you being pregnant. So some of the things that we need to go ahead and actually do prior to the IVF process is some evaluation. And so a lot of patients won't go directly to IVF. They'll usually go ahead and actually start with these more conventional treatment options like we talked about at the very beginning. Things like ovulation induction medications or inseminations, for example. So a lot of the testing and the pre-screening will have already gone ahead and been completed with your initial evaluation when you go ahead and come in for an infertility check. So some of the testing, like egg health testing and infectious disease testing and semen analysis, for example, might have already been done, but it is things that are required to go ahead and actually do prior to the IVF process. Genetic carrier screening, I think, is a really important piece to go ahead and actually talk about. So this is actually where we can go ahead and screen the couple with blood testing to go ahead and look at all of those genetic disorders like cystic fibrosis, like we had talked about before. Because if you are carriers, that will increase the chances of you guys passing these diseases on to a child. And that's where the IVF process with doing something like pre-implantation genetic diagnosis can help you guys to reduce that chance of you passing the disease on to a child. We'll also go ahead and actually look at the uterus specifically, because now that we've had egg and sperm combined in the lab to create your embryos, we want to make sure that we're going to put those embryos back into a nice environment. So this is where, like I said, that mock or dry run of doing the embryo transfer will come into play. We also typically go ahead and want to look inside the uterine cavity and make sure that there's nothing inside the cavity that would reduce the chances of pregnancy or increase risk for miscarriage as well. And then we always want to go ahead and obviously talk about finances. Oh, there's another question. How long does the total IVF process take? The IVF process actually takes approximately 4 months from start to finish. And that includes all of the evaluation, that kind of stimulation month and a half, creation of embryos once we have egg and sperm in the lab, and then all of the uterine testing prior to going ahead and actually giving you the medications to then put the embryo back into the uterus. So when we talk actually about finances, this is where I get, again, a lot of questions about IVF and cost. And so we sit down with all of our patients and discuss all of the associated costs with IVF, as well as making sure that your insurance doesn't go ahead and actually cover anything. So we do go ahead and accept insurance, and there are many places around the country that insurance companies do go ahead and pay for at least part, if not all, of the entire process for IVF. So it's really important before you go ahead and start seeking infertility treatment to make sure that your insurance has a benefit or does not have a benefit. You know, one of the common myths that I hear is that IVF is too expensive, and because it's an expense, I can't go ahead and afford it. And yes, IVF is expensive because it is a lot of technology, and it is expensive to go ahead and actually take eggs from the ovary and mix them with sperm in the lab and grow embryos in the lab, because you need somebody very highly skilled to go ahead and do that, as well as go ahead and actually have the proper equipment to go ahead and do that within the laboratory. So it's really important to understand that even though it might go ahead and feel like IVF is out of reach, there are a lot of financial grants. There are a lot of actually options for you to go ahead and finance IVF through banks or through companies, as well as then going ahead and making sure that your insurance goes ahead and actually doesn't cover some of the IVF costs as well. So these are just some pictures and diagrams actually of that uterine testing that I just talked about. The uterine Doppler that you can see on the right side of the screen allows us to look at blood flow to the uterus and help with implantation. And then this is actually for us to look at the uterus inside and make sure that the cavity looks normal. And this is just a little schematic actually of kind of looking at what that process looks like. So like I said, first month is typically kind of a pre-stimulation month and getting you ready for the process of IVF. Second month is actually going ahead and is allowing us to go ahead and get those eggs from the ovary once you've taken the medication, combining them with sperm to make your embryos. And then because we typically go ahead and do frozen embryo transfers, we come back and do that frozen embryo transfer in the 4th month after we've done all of your uterine testing in the 3rd month. I have another question actually. Do you need to take time off from the IVF process from work? You do. So I typically tell patients that the day of the egg retrieval, because you're getting anesthesia, you will need to be off from work that day. But like I said, 99% of patients will go back to work the following day. And then the day of embryo transfer and the day after, I typically recommend for patients to take off of work as well. And the reason why is because I just want you taking it easy and I want you to rest. And I want us to go ahead and just give the uterus some time to go ahead and allow that embryo to implant successfully. Other than that, all of the other testing, all of the other evaluation, as well as all of the monitoring for IVF, all can go ahead and be done around your schedule for work. And so just like I said before, I think the most important thing that you can go ahead and get out of this webinar is that you want to make sure that you read everything in very great detail before you go ahead and sign and before you don't go ahead and ask questions, because I would rather patients go ahead and ask multiple questions and understand the process than to go ahead and have an error happen and then we're looking towards having to cancel a cycle because of an error. So I always tell patients, most important thing is that you read everything and that you understand all of your instructions and that you ask as many questions as you need to feel comfortable with this process before you go through it. So specifically, since we're talking actually about IVF, why to go ahead and actually look at choosing them for fertility would go ahead and actually be something that I really want to speak to. So the reason why I think that you should go ahead and choose us for your care when it comes to fertility treatment is because we really, like I said at the very beginning, really treat you like family. We want you to go ahead and feel comfortable with the decisions that you go ahead and actually make. We also do not go ahead and discriminate against patients. We will go ahead and help you regardless and stuff of your diagnosis. We also pride ourselves in trying to make IVF specifically as affordable as we possibly can, because we want you to go ahead and get pregnant. And we want you to go ahead and obviously build a family. Your care is very individualized. We, again, really pride ourselves on making sure that we get an accurate diagnosis for you and then treat you for you, not to go ahead and be this cookie cutter of, we're going to go ahead and throw medication at you because there's nothing else to go ahead and do. We do go ahead and actually have cutting edge technology at the center, and we are going ahead and every day improving our chances of success for pregnancy. We do not go ahead and use IVF as our first choice for patients typically. We usually want to go ahead and use the most least invasive methods of treatment before and exhaust all of those before we have to go to IVF. If you need IVF and that's the option that you choose, great. But we certainly want to make sure that you feel comfortable with the decisions that you make for your fertility care. We also have a lifelong program for polycystic ovarian syndrome patients as well as endometriosis patients. And so not only do we take care of you for fertility, but if you do have a medical diagnosis for your fertility, we can help you with that in between your pregnancies or even after you've completed your pregnancies so that you go ahead and stay healthy actually once you have children. So if there's no other questions, then I'll go ahead and end the webinar, and I so thank you for your time and hope to see you in the office soon. So one of the questions that I'm getting is, what happens to the eggs that are not used? So like we talked about, probably about 10% of the eggs that we go ahead and actually take from the ovary are actually immature. And so those eggs typically cannot go ahead and be utilized. So we'll discard those eggs, unfortunately. But all of the mature eggs are the ones that we will go ahead and inject with sperm and go ahead and actually create embryos with. Some other questions that I get are, well, what happens if I have extra embryos? I usually tell patients, let's freeze those embryos for you, because with typically one IVF cycle, we can usually go ahead and get multiple embryos to go ahead and actually grow. And if that's the case, we freeze them for you to use for subsequent pregnancies. So always the goal is to try and go ahead and actually build your entire family off of just one IVF cycle. And that will obviously lower the costs quite considerably, but it also increases the chances of pregnancy for you because it really kind of freezes time. And then we don't have to be concerned about sperm health afterwards. We don't have to be concerned about egg health afterwards because the embryos are already created at the time that you've gone ahead and actually made them based off of your age and based off of your diagnosis. However, embryos that are left over after you've built your family, you actually have quite a few options. You can either discard them, you can donate them to research, or you can donate them to another couple. And we leave that option open to you. Well, again, I thank you so much for your time and look forward to seeing you soon. Take care now.